structural changes with function. And additionally, as a third point, is that we are looking on metabolism. Mostly, we are looking on inflammation or on degeneration. So every injury what we have is connected with a metabolic reaction, or a metabolic reaction can cause also a functional and additional structural change. So how do we look on the structure and on the function is clear. This is not a thing what we want to discuss, but what is mostly important for us is the metabolism. And when we look on the metabolism, what we do is we took drugs, medications, and we are trying to change the metabolism with some medications we give the patient, and so okay, this is something against pain, this is something against inflammation. But when we look on the medication what we are using, most of the medication what we use are metabolic blockers. So 95% or even more percent of the chemical approach we are using is to block on some level first pain or a certain kind of inflammation. And indeed, this is the only approach we have. We then have some physical approaches, especially then in rehabilitation or in acute case, when we use ice or warmth on a patient. But how do we make the definition? How much warm or how much ice does the tissue need? And not only depending on the swelling, depending on the pain of the patient. But we don't have any other information about it unless we make some laboratory examination and look how is the inflammation indeed, how is the CRP in the body, how are the leukocytes in the body. So, but we can sometimes only say, okay, CRP is high, so we have an inflammatory reaction, but what is when there is inflammation on CRP is in the normal range. So we have to look on something how we can explain some metabolic cases which we don't really understand. And as I already mentioned, that the possibility how we are approaching basically to something is that we take a hand, we feel is it warm, is it cold, and then we can physically help the tissue. So we will, do I have a stiff neck? So I will put some warmth around the neck, on the muscle. Or when I have an acute trauma, then I use ice for the first 1, 2, 3 days. But what is going then on? But now, when I say ice and warm, we are already make the difference between an hypermetabolic condition and hypometabolic condition. And somewhere in between is the normal metabolic condition of the tissue. And what is connected with this tissue? What is connected with this normal metabolic situation? The normal metabolic situation is connected with also the consistency of water in the tissue and ions and on the pH of the tissue itself. So what we see mostly that because we are an exothermic organism which produce always warmth, and so it needs always energy to bring in, which is spent in motion, in warmth, and this is why we spend also energy. So this is also connected with a certain metabolic situation which is in a normal metabolic range. Let's say in a normal metabolic range between point A and point B. And then there are other cases which are not normometabolic, as I said, which will need ice or which will need warmth, and these are hyper or hypometabolic cases. And how we can measure this, how we can be aware of this. So we know that most of the body energy is produced by ATP, adenosine triphosphate, 95% of all energy of the body. And this needs a certain differentiation of ions beside the cellular membranes. So we have always, the life is its expression of separating different concentration of ions beside the biological membranes. So we know that we need to keep this differentiation of ions, and this must be done by what? By pumps, certain kind of pumps which pump iron across the membranes. And when we have some cardiac patients, we know that we have to block some calcium that is not going into the heart, so we can stop, let's say, extra high pressure. We can reduce arrhythmia and something like this, but we block these channels. We block this ion transports. But in a normal life, there is a certain kind of divide of concentration of electrons, and this all needs to be run by ATP, adenosine triphosphate. And when you know how much energy we know in the body, so guess how much ATP we use in the body per day. When, let's say, you have 85 kilos, so what do you guess how much energy or how many ATP do we need for living per day? So this is at least your weight, your body weight. So more than, let's say, 85 kilos is used for the life, to stay alive during the day and to keep up our normal activity. Especially when we are sportsmen, we need much more, up to 4 to 5 times more ATP than the normal people. So ATP is the main gate of this. Of the metabolism, and we know that the energy, the ATP, is produced by a certain kind of concentration of protons in the mitochondria, and but we measure this energy. We call this enthalpy. It is measured of a total energy that called heat content of a thermodynamic system, so of the body tissue, and represent a concentration of protons beside the biological membranes. And we don't call it heat content, but we call it free enthalpy, because we are an open system. We are not a closed system, but we are an open system, and we call this Gibbs energy. This Gibbs energy is a certain kind, is a free enthalpy, and this is measured by Joule. And this energy, this Gibbs energy, can be over a certain physiological level or below this physiological level. So delta G can be zero, which is almost never zero. It always fluctuates around the zero, or it is under zero, so we get some influx, and when it's above zero, we got some energy efflux. So I don't think that this is the basic of all the biophysiological way to think, but it is sometimes very difficult for us as doctors to work with this, as I say, with this physiological basics. But it is very important to understand it, because the situation which we are working with is much easier than all this explanation. The whole explanation is that we are working only with two pathologic metabolic situation, and these two metabolic situation can be normal metabolic, is physiological part, or hyper or hypometabolic, as I said. So let's say you have a knee, you have a swollen knee, and this is a situation which we call delta G is negative. So it's an exothermal state. So we will feel that this knee is warm. And what would you put on the knee which is warm? You would put some ice on the knee. Is it true or not? Hello, everybody?
Yes. Yes. We are here, sir. We have some new entrants.
When new person.
Yes. It's okay. So you would put primarily when you have a swollen or injured knee, you would put ice on it. Okay. So this is a exothermal state with the delta G, also the Gibbs energy is negative, so the warmth is delivered. And we, in this case, we will put ice on it. So we are trying to cool the metabolism down. In the opposite case, when we have, let's say, a frozen shoulder, so what would you put on a frozen shoulder?
We generally go some thermal hot short wave or something.
Exactly. So you try to restart energy flow in the tissue. Okay?
Yes.
So the warmth is taken up by the tissue. So there is the delta G is positive. We call it endothermal state, and the other one is an exothermal state. So, and we can feel it by our hands even when we touch the patient. So you have the impression, well, this tissue is cold, you know. It's and on the other side, you feel that the tissue is warm, and we can actually see that these are different two metabolic cases. But these two metabolic cases are always copying the situation which is in which the injury is in that moment. And when we have, let's say, the knee. There is a bone, there's a cartilage, there is a capsule, there are soft tissue, there are tendons, there are muscles around the knee. So all these different kind of tissues participate in a different manner in the injury. So in one injury, the bone is more affected. In the next injury, the soft tissue, the capsule, the tendon is more affected. So not every tissue around the knee is affected in the same way metabolically like the tissue which is connected with the highest damage. So we have entropy, metabolic entropy of different states of metabolic states in one area. And when we look at it, so we apply some cortisone, we apply some antiphlogistics, but we are approaching the tissue which is mostly affected. And when we have inflammation, so it is very easy sometimes to cut down the inflammation. But what is following next? And this is a big deal which we can't follow. In which condition is the tissue then when the inflammation is gone? And so all the different structures like muscle, tendons, bones, capsule, fascia, bursa, skin, soft tissue, periost, lymphatic vessels, organs, or nerves, they all together build up a metabolic entropy. This entire entropy is in a diabatic tissue is formed by a summation of metabolic conditions of these different structures, and physically it is comparable with a stochastic resonance. And so it is very difficult to say which tissue is mostly affected in which on which time of the situation, because in the first acute state, we have one part of the knee is in a certain metabolic condition, and one part, some kind of tissues are affected more than the others. But when 1 week later, when we look at it, it can be totally different. There can be the soft tissue reaction can be gone, and the fracture, which is around the knee, still exists. So there is more. On the beginning is more than after 1 week the bone affected than the soft tissue. So altogether, we have to be clear that we have to work with two pathologic cases, which are hyper or hypermetabolic. And what is our goal? What is the goal of it? We are trying to bring back the tissue in a normal metabolic condition, because we know that the metabolic in a physiological range, the tissue is behaving very much faster than when it's inflamed or when it is when is degenerating. So there is a turnover is too high or the turnover is too low, and we know that in a physiological range the turnover is ideal. So the regeneration and rehabilitation under this condition is much better. So do you come up with this what I said till now?
Yes, we're able to understand.
Yeah. So when you look in China, they say, okay, we have yin and yang. Maybe you have in India something similar.
Yin and
do you have something in India? Something like yin and yang?
No, we don't have.
No? But you know what I mean. You know what I mean, yin and yang, how the Chinese explain things.
Hot and cold.
Sorry?
Is it hot and cold?
Yeah, yes, no, yin and yang. Yin and yang, these are two different, let's say, conditions, metabolic conditions, but also psychological conditions and so on. So
generally, we used to say when there's an inflammation,
yes,
the part is said to be warm, no?
Yes,
if it is
yes.
warm is there, we say there's an inflammation is there.
Yes. But do you think that there is always an inflammation when there is when it is warm?
Not so.
Because I have done the experience that not all inflammation is warm. It can be also normal metabolic inflammation.
Okay.
And something can be also warm without being inflamed. It can be only the blood circulation can be only higher. So this can be also warm, okay. Cause warm. Let's say you will give some warm cover on the muscle, so the muscle will be warm, but it will not be inflamed. Okay. So the interleukins 6, 8, 10 are on a normal level, but they are not inflamed. And CRP is also. So there can be also some warm metabolic conditions which are not inflamed, but we normally say also here it is an inflammation, and in this case you will give some antiphlogistics normally. Okay. Is it true?
Yes, correct.
Yes, and but why don't we use in that case ice?
So in acute inflammations, generally we go for icing. Once
icing.
Very acute.
Yes. So it is also possible, when with this, what we are looking for, how can we cut inflammation down and how to understand it. And when we look, we have, let's say, I will give you an example. We have arthrosis, knee arthrosis.
Okay.
So knee arthrosis, it can be inflamed or it can be without inflammation.
Yeah.
Okay, so but normal arthrosis, let's say a degenerative arthrosis, can switch to inflamed arthrosis in case I overload this arthrotic knee.
Yes.
I'll go somewhere, I start to work, I go stairs, I go to the mountains, and then come back and I have a swollen, thick knee. And then this degenerated knee, which was before, let's say, only degenerated, is now in an acute case.
Yes.
So you will try to cool it down on some antiphlogistic, some ice, and then you hope that it will get back to this case which was before.
Yes.
And so we see that we can have in one situation, in one part of tissue, in one kind of diagnose, we can have two different metabolic conditions. And this same is that we can have, like in example, the shoulder, we can have two different conditions beside each other. We can have a degenerated rotator cuff in the tissue, but we can have at the same time a bursitis. And these two different conditions, the rotator cuff is a degeneration, is a hypometabolic condition, and a bursitis is a hypermetabolic condition. Okay? And so we have two different metabolic or opposite metabolic conditions close to each other and in one location. And this is how do we treat this? We first treat the bursitis, which is acute, and then we start to treat the degenerative rotator cuff with different kind of approaches, physical approaches, and so on. But we have also another possibility. We can we have to break down the metabolism in the bursa and restart the metabolism in the rotator cuff. And this is always connected to the function of the tissue. So we have the tissue of the rotator cuff mostly has a longitudinal function. So for the elevation and sometimes rotation of the shoulder, and the bursa has a structural function which is going across the tissues. Of the muscle is longitudinal, but the function of the bursa is transverse. And so we can make differentiation which kind of tissue is more involved in that. And we can, with this Luxxamed approach, show also in the measurement that the different tissues are in the same situation, differently affected. So I can, with the therapy, I can in one moment, in the same moment, I can accelerate metabolism, and in the same moment, I can break down the metabolism. And when we know how the tissue is working, so we can apply the electrodes, and then we can see that the metabolism, that the curves, first which were up and the other which was down, they cross each other.
I just have one. So we have Dr. Kaushik, and he's an orthopaedician.
Hello.
Okay, hello, nice to meet you.
Yes, nice to see you.
Hello. So,
Hi.
hello. So we are still in an advanced situation now, but hopefully you can review this discussion. And so at the same time, we can cool down, and we can apply ice, and we can apply warmth on one location, which is very interesting, because always metabolic situations are connected to the function of the tissue itself. So these kind of metabolic approach is called also ECC, resonance electroconformational coupling, and which shows that the membrane ATPs are capable of absorbing free energy from applied oscillating electric field and converting it to chemical bond energy of ATP or chemical potential energy of concentration gradients of phosphate. And that means that when with a certain kind of physiological current which we produce with this Luxxamed, it is possible to bring energy into the tissue on a physiological level, or take it out. And because we are working on a physiological range of electric flow, we don't have any side effects, because we are copying, or we are offering the tissue some physiological information which the tissue is transporting into its metabolism. When we look at the oxidative phosphorylation from complex 1 to complex 5, so we see that it is only an electron transport. It is nothing more than an electron transport. Without electron transport, there will be no energy gain in the mitochondria. And so we are copying this electric flow and offering it to the tissue, and the tissue can accept it or deny it. But we can, when there is some leak of electric flow, so we will offer it. We can restart energy flow, like in a degenerating tissue, or we can take away the energy when it's overloaded, when it's overheated, and the energy flow is too high. So we can transport with this application of the Luxxamed. We can change the situation from delta G, from this Gibbs energy negative. We can transport it to positive situation, or we can transport delta G positive energy into delta G negative energy. So this is the same what you do with application of ice or warmth on the tissue, but this is controlled and this is visible. So we can see what is happening. We can show it on the curves, if probably Mr. Kumar already showed you, so that there is a reaction of the tissue. But a lot of patients, they come and they take some medications. They have 1, 2, 4, 5, or even 10 medications which they use, drugs, and mostly of them, as you agreed, are blockers. So we have, on the beginning of the therapy, we have to overcome some block, and the block, it takes time, maybe 1 session, 2, or even 3 or 4 sessions before we break through this chemical block, and then the therapy can restart. Mostly it takes 1 or 2 sessions before, in such cases, before we break through. And we see it with this cholesterol.
Voracek, can I interrupt now? Are you suggesting that means during the process of the treatment, the drug intake has to be stopped?
Sorry, what has to be stopped?
The drug intake.
Well, the drug intake. Well, sometimes you can't you can't stop all drug intake, but I'm trying to do it. Let's say when some basic cardiac medications, I don't do this with cardiac medications. But where I try to do it is, let's say, with this cholesterol medication, which cause a lot of soft tissue problem. With joint problems, and so I try when they have even a higher cholesterol, I stop this medication, and I'm looking for other kind of parameters which are more important for the cholesterol than only the level of the cholesterol itself. So that means that I'm looking on the homocysteine, on vitamin B, folic acid, of zinc, how much, and selenium, how much is it in the body? Because when the homocysteine itself is on a low level, so the cholesterol has less chance to be active on the vessel itself. Do you have some similar experience with this? Or you don't look at these kind of problems that way?
So probably when certain patients who are taking statins, they may have this muscular pain.
Yes,
but
exactly.
You can differentiate between the actual pain and which is due to the statins also.
Yeah, the statins we see on the measurements that they are blocking us often very strongly the metabolism in the tissue itself, and so I'm trying to stop these statins and mostly, as I said already, looking on other kind of parameters. What is the limit in India for you to give somebody statins?
I think it was 200 is normal, it's 250 or 260 and above.
Okay, because we have
we still diet modification, exercise, certainly once above 300, yes.
Yeah, okay. Because we have here in Germany, and Europe also mostly, these are 200 up to 220, and milligrams per deciliter, and this is I think too low. Is too low because I have some patients which have high cholesterol up to 300, and when you make a cardiologic examination catheter, so you don't find anything in the vessels, and when you look then on other parameters like this homocysteine, inflammatory reactions and all that stuff, then you see these are in a normal range, and only the cholesterol is dangerous in the case when I have besides inflammatory reactions somewhere in the vessel system. And so I mostly try to stop most of the medications, but because this is easier for us. But we have a correcting factor in the Luxxamed that when patient takes these medications, so we give it, we pre-program this in the program, so you can apply it, and so the measurement of the tissue will be corrected by a correcting factor, and so then we get closer to the real situation in which it is truly is. So when I give somebody also an antiphlogistics, so my antiphlogistic measurement is not on the low level like it was before, but it climbs a little bit up. So then we don't have any idea in which situation is the tissue really. So there is a correcting factor, and we are bringing it again with this correcting factor on the true position. And as soon as it is possible to stop with the medication, so I do this. Okay, so let's go to the.
Dr. Voracek, can I ask a question?
Yes.
Like Professor Voracek, he always says that all pain therapy devices work. They are static systems, whereas this is the first one that's a living system. And can you talk more about the bio-cybernetic technology?
Well, the thing is that what we are with this approach is that let's say you start to make therapy with some patients, the tissue itself changes. So one day the patient comes into your office, and so you will find him under certain condition. So depends on he's nervous, he was running before very much, or he eat too much, or he didn't drink too much. So the body is an open system, and every day you will when you meet the patient who comes from outside, so he will be under different condition, and because this is changing every day, we have to accept this, and we can't do anything with this. But what we can do is that when we connect the patient and we measure it, that after a while the device is able to find out in which condition which is the true condition of the tissue itself. And because the tissue is changing during the therapy, so next time I have another condition. So the device has to react on the situation that it is under different condition, and then change also the modulation of the current itself in the next day. And the third day again, and the fourth day also. And so when there is a certain kind of algorithm connected in the device, that when the energy flow in the tissue under certain condition achieves a certain amount, then we know that we can change, or the device knows that it can change the modulation and bring down again try to bring down the tissue in the physiological range. So on the beginning, when we have some inflammatory reaction or high metabolic reaction, we are cooling the tissue strongly down. And when we have a hypometabolic condition, we are trying to warm it up. And then after a certain time of cooling and icing or warming up, we bring the tissue in a normal metabolic situation. And when we see it, let's say after operation, so when we operate some patient, we see that we have a certain kind of reaction of the tissue, of the skin, of the soft tissue, and of the operating area. And we see that there is a inflammatory reaction because we have a damage of tissue, and there is an inflammation. The pH of the tissue is on a lower level, so the pH goes down. And when we apply the current on it, on the Luxxamed on it, so we cooling it very fast down, the inflammatory reaction, so the scar building and the healing can be cut up to 50% of time than we usually need. And this is very interesting to see it when for people who operates, that the regeneration after the operation can be cut up down to 50% of the time. Okay.
You are talking about using the machine after operation.
Yes.
Okay.
And so what you're trying to do when you operate somebody, so you give a lot of my colleagues, they give some antiphlogistics for a couple of days after the operation to cool down the inflammatory reaction. But we can do it also without this medication, because medication had side effects. And but with this application, we don't have any side effects. And especially, we are much better because we can restart and start the healing of the tissue. And you see that the scar building is much nicer. The scars are softer. They are not that hard. We don't have these complications after the operations that much with healing, with wound healings. Also, it can be as prophylactic to inflammations. When I was the head of a rehabilitation clinic here next by for a couple of years, and we got a lot of patients after operations to the rehabilitation clinic where the wound conditions were not optimal, so we couldn't work with these patients properly. And then we had first to improve the wound situation, and we have done it with this clinic master or with this Luxxamed device to bring it down. and restore the wound situation before we could put the patients in the water rehabilitation approach. This is mostly what we also use here.
You mean to say the hydrotherapy? You wanted the wounds to heal.
Yes. So we are trying to enforce the wound healing, which with cutting down the inflammatory reaction just directly after the operation, and then the wound healing, because mostly the big problems are that we have a hypertrophic scars, because people often have a strong inflammatory reaction after the operation. And when we cut down this inflammatory reaction, so we don't have these hypertrophic scars.
Can you hold as a question?
Some amount of inflammation is required for wound healing. But you're saying you just tone down, you just cut it down.
Yes, but we don't cool it only blindly down. We cool it only down blindly, because normally you take ice and you don't know how long can I keep the ice on the tissue. But the device, because it's measured every treatment, every second, there is a measurement during the therapy. It sees how the tissue goes down, and when the tissue achieve a certain kind of level, so it changed the modulation. So we achieve another kind of approach in that same situation, because we have over 5,000 enzymatic processes happening every second in our body. And how can we make differentiation? What is between these 5,000 different enzymatic processes? How we can make differ it? It is very difficult. So we have to look for a certain kind of information which connects these. And we know that the most pathologic situations are the dominant elements when we make physiological measurements. And what we do, we measure a physiological metabolic range. We don't measure like we have electro EMG. So this is a gate control system on the nerves, and which works much higher with much higher energy flow. But the tissue itself is working on in a range of micro or nanoamperes, and not with milliamperes like a classical electrotherapy. Because this is like when you would take your fingers and put it into a plug, so you will get probably a shock. So that's why we also abandoned most of the classical electrotherapies, because the long-time effect is very little, as they work as electric anesthesia. So you can cut down the pain with a classical TENS therapy, but you're working on the nerves. You are not working on the tissue itself, and you must be aware of it, that you're working with this gate control system. You are not working on the tissue.
So the TENS or the IFT, everything works on the pain gate theory, no?
Exactly. Everything is working on the pain. So I call it, it's a electric pain therapy, but it's not a metabolic therapy. And the most causing reason for pain in tissue is what? You know what it is? What causes in the tissue the pain?
Metabolic imbalance.
Yes, but which kind of metabolic imbalance? There is a big study about this, and they found out here in Heidelberg on the university, they have done this study, and they found out that the most causing pain situation is caused by the drop of pH in the tissue.
pH, okay.
but you are not changing the pH with TENS or classical therapy. You are only cutting the nerve. You are stopping the transport of the nerve. You make a gate control, and that's it. But you are not changing the pH in the tissue itself. And so what we are trying to do is to have influence on this situation, to cut down the pH, to bring it to the normal metabolic range, and then we have almost no pain. So because we are working on the pain on the basic, and because a lot of the tissue itself it is exhausted. When we have some chronic inflammation situation in the tissue, what happens there? This is like an empty battery, which is always only reloaded by dynamo, but the battery load is very little. The battery load is very little. So the ATP, which is produced in the tissue, is immediately transporting into the production of heat, but not in recovery. So you have to bring also ATP into it. You have to restart more production of ATP. We have recyclication of the ATP 3 times a second in the tissue, and that's it. And that means that there is always an ATP turnover from ATP to ADP and ATP, and this 3 times a second. But in the exhausted tissue, the energy turnover is very little. It's very little. And this same is that there is no energy turnover in a degenerating tissue itself. So there we have to restart the energy flow, but also in a exhausted, inflamed tissue, we have also to restart it. But we can't restart it with heat. We can restart it only that we produce more protons, and then we offer the tissue something, and then it restarts itself. So we are not abusing the tissue. We offer the tissue something, and we are working now over more than 15 years on this on this base. So we're using this microcurrent-therapies since more than 15 years, and we have learned a lot about this, and we still learn and still learning how can we improve it. And it was interesting that the whole development. So first we came from classical energy, from a classical electrotherapy way to think, and then change very soon our approach and started to find. I was looking for explanation how these things are working, and this excuse me. And this kind of explanation comes very close to the reality. And since we can, with the new devices, we can show also on the curves, we can understand it more. Even the curve sometimes gives us some information which can also confuse us a little bit, because we have a completely other imagination about the metabolic situation in our brains, because we have learned it another way. And suddenly the device gives us some curves and said, okay, this is not possible. I thought it is inflamed, but now I understand in the background of the inflammation there is a degeneration. Let's say Achillotendon, achillodynia, okay? Achillodynia, we have a peritendinitis we can have, which we see on the ultrasound, and we always have a swollen achillotendon in both situations. But in one situation, it is combined with the inflammatory reaction, and in the next situation, is combined with a degenerative situation. So how do you normally make the differentiation? How do you make normally differentiation? You make ultrasound, you see it is a swollen Achilles tendon, okay? And in both cases, it's swollen. And how do you make differentiation in the therapy? How do you make the differentiation? It's very difficult to say. Yeah, but in one situation.